Welcome to the award-winning Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our mission is to educate, advocate, and inspire women in healthcare to lift as they rise. Each episode brings you voices of leaders who are breaking barriers and leading the way in advancing women's health. Join our global community of listeners as we hear from her. Ready to be part of the movement? Let's dive in.
All right, guys, today's show is going to blow your mind, literally. We're talking about rewiring the brain with magnets, electricity, and some of the most cutting edge science out there. And I've got two absolute rock stars in the neuromodulation game joining me. Dr. Carolyn Rodriguez, Stanford psychiatrist, researcher. She's out there pioneering rapid acting treatments for OCD and hoarding disorders. And Dr. Colleen Hanlon, Brainsway's Vice President of Medical Affairs, who brings over 20 years in brain imaging and deep transcranial magnetic stimulation experience. She's been on the front lines of bringing this stuff from the lab into real people's lives. So, we're going to talk about what it actually means to treat the brain as an electrical organ and how this is changing the landscape for depression, addiction, and OCD, and what the future could look like when we flip neural circuits on and off like switches. This might be the type of science that feels like sci fi, but it's happening right now. So let's flip the switch on the brain's hidden circuitry. Let's begin with our origin stories and early curiosity. So, Colleen, I would love to ask you what sparked your early interest in the brain and going into this area and becoming a scientist in the first place?
Hey, Joanna. Thanks for that. I'm really excited to be here and chatting with you and Dr. Rodriguez. So, I guess my curiosity of the brain probably started when I was in undergrad. I was at the University of Florida. And at the time, I liked to play tennis a lot. I wasn't good enough to play on the UF team, but I played a lot of intramural tennis. And I remember one day I was, taking some probably basic neuroscience classes, trying to be pre-med. And I was playing tennis with this girl. She was on the other side of the court, and the ball was coming towards me, and I was hitting it back to her. And at one point, it was like time stood still, and I thought to myself, how is it that I see the ball approaching her racket, and somehow my brain can figure out exactly where I need to be and what position I need to put my arm and exactly the right time that my brain expects her ball to arrive at a certain point on the court. And then, not only that, but it was pretty good at the time, not anymore. But I could also figure out where to hit it such that strategically I thought she wouldn't be there. That is just an amazing amount of computation that your brain does in an instant. And you look at these tennis kids that are playing at even like 7, 8 years old, and they can do all of this. And that's probably really why I got the most excited about the brain.
That's a really great story. I love that from the first time that we met, actually, that when you told me that story as well. So I'm glad you repeated it because we just wrapped up the US Open and you could really see that dynamic in action, especially with some of the younger superstars that are coming into realm right now. So that's really cool. And a lot of scientists do also have medical and sports backgrounds, which I find fascinating because their brain is kind of exercising different parts of itself and helping them to put it all together where it counts, right? And so now, that's a great story. So now I'd like to shift gears to Carolyn. So from reading your biography, it was clear to me that you had initially completed a computer science degree and from Harvard, no less, before moving into psychiatry. Was there a moment that you realized that the brain's code is electrical, almost like a computer? Was there a connection, and how did that shape your scientific path and your journey into this area?
Jovana, great question. And yeah, very early on have been really interested in where things go awry. And based on Colleen's wonderful story, I was thinking, and I wonder why it is that my brain sends the ball to the wrong part of the court. So
I originally from Puerto Rico, and when I was younger, spent a lot of time with the relatives, and I would was definitely into computer games early on. And my uncle and I would play games, and he would talk to me. We would both kind of talk at the computer and the screen, right? But he would also talk to somebody else that wasn't there, and that was really something that I thought a lot about as a kid. In speaking to my grandmother, why is Theo talking to somebody who's not there and trying to get some answers? It was kind of something that was not talked about or discouraged to really think much about. In the spirit of being very inclusive, like he wasn't, we're trying to not make him feel different or anything like that. But anytime somebody tells you to not think about something, that's pretty much what what I was thinking about. It turns out, of course, that my uncle had schizophrenia, but that curiosity, what are the thoughts in his mind? Why does it drive him to see things that aren't there? Really persisted throughout my academic journey, and particularly, why it is that some people have these kind of intrusive thoughts, and they can see that they are, um, you know. Impacting their life, and for some people, they're not. So that's where it started.
Thank you for sharing that story. I think definitely when we think about these conditions, traditional treatment tends to focus on pharmacologic interventions. What is wrong with my dopamine receptors? What is wrong with my acetylcholine signaling? What is wrong with my serotonin? What is wrong with all of these neurochemical imbalances in the brain where we traditionally have thought of these disorders as targeting those pathways, and also in some ways as neurodegenerative disorders, right? What pushed you to kind of, and this is a question for both of you, go into the field of neuromodulation specifically? Because when I think of neuromodulation, I think uh, definitely leveraging a part of the brain that we talk much less about, and also much less invasive to pursue. So therefore, potentially more favorable for patients who are they've experienced a lot of side effects with traditional treatments. Let's face it.
Yeah, I guess I'm happy to jump in there. So I think we've known that the brain is both a chemical organ and an electrical organ for a very long time. You could argue we've known that for 100 years. But we really haven't had any way to non-invasively modulate the electricity in the brain until very recently, right? We've had pharmaceutical agents for a very, very, very long time. So we've known how to intervene on the chemistry. But outside of kind of really invasive procedures or things that really nobody wants to get or they require neurosurgery, it wasn't really until the early 2000s that we had non invasive neuromodulation tools that could look at the electrical side of the brain. So for me, I was a postdoctoral fellow at Wake Forest at the time, and I was in a lab. We were using brain imaging, functional MRI, which was like cool new technology at the time. And we could take great pictures essentially of people that had addiction, and we could sort of predict whether or not they were likely to relapse. But across the hall from me, my friends were using like electrodes and a technique called optogenetics, which allows fiber optic cables can be implanted in the brain, and then basic scientists can shine different frequencies of light on the brain. These guys were showing that there's a causal relationship between the frequency of firing and drug self administration. So basically, if they shine blue light, the animal presses a lever for cocaine. And if they shine yellow light, it stops. So that kind of shows a causal relationship with the electrical circuits in the brain and behavior. And then we couldn't do anything non invasively in humans. And then all of a sudden, this technology called transcranial magnetic stimulation, which was first used in the motor system, which, as I mentioned, I really liked the motor system, in stroke recovery, had been FDA cleared for treating depression. So, that was great. I was an addiction researcher at the time. And I thought, well, gosh, we really know the circuitry of addiction probably a lot better than we do depression. So maybe we can try and use this non invasive tool to change the outcomes for addiction. So that's kind of how I got started, I would say.
That's fascinating on so many levels and has so many different applications. Just this weekend, I was at a conference and there was a technology at this conference that was a medical device where you could actually stimulate your trigeminal nerve and it helped show efficacy for migraines. So there's so many potential and amazing applications of this that we're not fully realizing the potential of. And so I'm curious to know, how did you two meet? Is that how you made the connection? This neuromodulation passion?
Yeah, well, for me, I have been a long time fan of Colleen's work and knew of her as an expert in neuromodulation. And I just remember one time where I was really just, in the research that I do in obsessive compulsive disorder, we have some first line treatments which include, chemical drugs that alter the chemical composition, like serotonin reuptake inhibitors, and therapy. And these one of these first line treatments will help about half of individuals, but even with second and third line treatments, only 7 out of 10 are helped. And so I was really starting to look at, are there other ways to be helpful? So not one size fits all, right? And so with a colleague, we started thinking about the already FDA cleared TMS for OCD, but was there a way to do it faster and more effectively? We tried a lot of different ways in a pilot study, but it was really Colleen giving a presentation at a conference called ACMP, American College for Neuropsychiatry, where she was presenting on a type of stimulation that she was doing localized in the front part of the brain, the right frontal pole, that was she was saying could be really helpful for addiction, for craving, and kind of had this light bulb moment where I was like, I wonder if we're just not if we could target this place, it could be really helpful for individuals that struggle with these kind of very intrusive and unwanted thoughts.
That just clearly makes the case for why we should all keep going to conferences, being there in person, and listening to these compelling presentations. So when I think about this again, I think about obviously these conditions from the context of how they impact women as well. And so would love to hear from you, Carolyn. So you manage OCD, but also hoarding. And we talked about that previously. Can you tell us a little bit about the prevalence of these conditions and how do they impact men and women in different ways? And have you seen differential strategies that you can use to manage women versus men? And then after that, I really want to ask Colleen how to walk us through like what a typical neuromodulation session looks like, because I think our listeners would really appreciate to know what that experience could look like. But I would love to hear from you, Carolyn, first about these conditions a little bit because this is your area of research and your passion.
Yeah, absolutely. So, OCD is short for obsessive and compulsive disorder, and it's comprised of intrusive thoughts, images, or urges that increase anxiety, and then repetitive behaviors or compulsions that serve to neutralize that anxiety. And the prevalence is around 2%, and we think it affects about women and men equally. Then turning to hoarding disorder, this is a relatively new diagnosis in the Diagnostic and Statistical Manual that we use in psychiatry. In 2013, it became a disorder, and it's characterized by persistent difficulty parting, letting go of items, and this associated need to save and distress in parting with possessions. which then results in clutter. And there have been a lot of different kind of studies of prevalence. We think the best estimate of prevalence is a meta-analysis, like a grouping of 11 studies showing the prevalence is around 2.5%. So a little bit more, a little bit higher than OCD. And although in terms of these studies, it shows that the prevalence is about even for women and men. What we see overwhelmingly, sometimes 2 to 1, 3 to 1, women enrolling in research studies. And so there's been a lot of questions. So why is that? Is there potentially, women may feel more comfortable seeking help, or is it something having to do with insight, the ability to tell if these specific symptoms are distressing or not? So the jury is out on that one. Yeah.
For sure. And potentially even more stigma towards women because traditionally perhaps we are thought of as being more likely to hoard. And so if we are hoarding, for example, excessive clothing and things like that, maybe we'll come to that realization sooner than then.
Yeah, Giovanna, thank you so much for raising that, which is stigma is a big part of hoarding disorder. And, not only do individuals struggle with the lack of being able to do things in the house, social, work, like, for example, like have a client who's a grandmother who it can't have her grandkids over because she is like embarrassed, she's worried, she doesn't want to have the clutter fall on the grandkids. So not only is she's suffering from that, but also, you know, sometimes people feel like this is a moral failing, or sometimes family members cut off family members. So that is something that is very, very heavy for individuals as well.
Absolutely. And, when we think about societally, right, we live in highly developed nations where things are readily available. And so there's even been TV shows that have been made about hoarding disorder now. There's really increased awareness about it, but still it's not being maybe seen as a medical condition. So I appreciate you making sure that this is being recognized as something that we can change using appropriate treatment and really increasing awareness on that. Because I think it's important. It's like any other disorder, like even like OCD, it's important to help people at the end of the day. So appreciate you and the work that you do to increase awareness about this condition. So moving to Colleen, we've heard from Carolyn regarding how we manage patients, potentially how we can help to utilize neuromodulation in these conditions, in combination potentially with pharmacologic treatment where appropriate. I think our listeners would be really curious to hear from you as to what a typical session might look like. What is that experience? What is neuromodulation? What does that experience actually look like?
Yeah, of course. So, as you mentioned, Jovana, there's actually now there's a lot of neuromodulation based devices. So, usually, this word neuromodulation kind of can be thrown around in many ways. Usually, we're talking about a device, and usually that device is non-invasive, meaning that it's wearable. And there's a variety of them. The one we probably have the most data on is TMS, stands for transcranial magnetic stimulation. Um, so TMS is FDA cleared for depression. That's probably the biggest use of it. But also, as Carolyn was talking about OCD, it's increasingly used for OCD. There's also an indication for smoking cessation and a peripheral pain indication. So we see the indications growing and growing. The treatment profile is a little bit different for each of them. But since most people are probably interested in depression and OCD, um, I'm happy to say that major health insurance companies in the US pretty much all cover depression. Um, we're not there yet with OCD, but the coverage is increasing, which is great. So it makes it more accessible to people. And really, the only absolute contraindication for any of these technologies is having metal in your head. So, which is great. So very few people have metal in their head. This would be people like that have a deep brain stimulator or something like that. So typically, a patient, in order for insurance to cover it, usually the patient has to have tried and either not had a response or didn't tolerate two standard antidepressant medications, or this similar situation for OCD. So they come into an outpatient clinic typically, and then they'll usually sit down in the chair and there'll be an initial dosing metric. So one of the cool things about TMS is that before patient-tailored medicine was a buzzword we were all chasing, TMS has always been titrated to the person, right? So usually you take a standard dose of medication and it's not based on your milligrams per kilogram unless you're inpatient, right? But actually, TMS is always based on your specific biology. And the dose is based on this thing called a motor threshold. So you would sit down in a chair, usually within about 15 minutes, the provider would place the TMS coil on your head. So some TMS coils are like a helmet, and some of them are more like sort of a plate. But they kind of go on your head and touch the surface of your head. And then they will, the coil, when it's activated, will apply single pulses. So not to be too physicsy, but this is based on physics from the 1860s, that electricity and magnetism kind of hold hands. So if you have electricity and it flows through a coil, and that coil winds around, it creates a magnetic field. And if you take that magnetic field and you turn it on and off, that creates an electrical field. The way I like to explain this to patients is it's just like a wireless charger for your phone. So if you were to take that wireless charger for your phone, which is like a coaster, and you were to open it up, you would see basically a mini version of a TMS coil. Just a wire that's wound up in a circle. And your phone doesn't have energy in it, let's say, right? The battery is low. And then you take this phone with low energy and you place it on top of this coaster. And then with no wires connecting the phone and the coaster, magically electricity goes from the coaster to the phone, right? That is exactly how TMS works. That process is called electromagnetic induction. And so in the same way, we take a coil and we place it over your head, and it, through magnetism, restores energy to the circuits that it's touching. So for the case of depression, we stimulate the lateral prefrontal cortex. As Carolyn was describing for OCD, we like to think about the orbital frontal and the medial frontal cortex. Anyway, all of the science aside, you go in, you sit down in the chair, and they'll do a dosing procedure on your head. So they'll try to figure out exactly how much energy is required to make your hand move. They figure the dose. That's usually just done on the first session, maybe once a week. And then typically you'll be asked to come back to the provider's office every day for about 5 days a week. So every day a week for usually a total of about 30 to 36 sessions. And it can be daily or it can be daily for a few weeks and then spread out. Each session lasts anywhere from 3 minutes to 20 minutes. There's a variety of things that happen in that difference. And basically it feels like a tapping sensation on your head. So if you imagine you had like a little bit of a fingernail on your forefinger and you just tapped on your head like a little bit like a gentle woodpecker. That's what some people refer to it as.
Love that.
That's really good.
So that's what it feels like. Usually, I mean, you're not going to sign up for it for pleasure. But most people, the first day, it's challenging to tolerate. But usually by the second or third week, people actually tend to fall asleep while they're getting the TMS, and the provider tries to wake them up. Anyway, so each session is, you could expect to spend about an hour in the physician's office for a session. One thing to just add to that is that that standard sort of run of the mill TMS that's now given all over the world to treat depression. Um, and but there's a huge momentum in the field today, and Carolyn mentioned this earlier, of accelerating the treatment. So instead of asking people to come back once a day for 30 days, which is a decent amount to ask for people that need to rely on transportation, etc. Um, there's been a lot of push, as like Carolyn's study, of condensing multiple sessions into one day. And so there's people that have looked at 10 sessions per day, 5 sessions per day, 3 sessions per day. Um, so I think we're going to see a lot of change and positive evolution and innovation in this space, which really will promote access to TMS, which is a big thing that we're all interested in.
Absolutely. I mean, that is fascinating. And traditionally, when we do think about these disorders, though, from my world, we always discuss them as neurochemical imbalance, and we tackle them using mostly traditional treatments. There are some novel treatments on the horizon that are leveraging different mechanisms, but they still come, with a ton of side effects and obviously access barriers. So, do you ever see a world, Colleen? And I really love how this is now being considered to be a bit more effective in terms of, let's say, combining multiple sessions in one day and really trying to it encourage that adherence for the patient to keep coming in for that and making it easier for the patient.